All right, welcome everybody. We have SDR on and we have Oak Review on. We will get started. Today's topic for the eCW universities to learn a little bit about the E&M coder and just some different billing practices. Many of you are probably pretty good at that. It's a pretty simple thing, but I've had a few questions on it, so I thought we'd do a university about it to just do kind of a Q&A session around it and kind of see if it works for you, and then we can talk about kind of anything else that anybody else wants to bring up. We do have one question from Dr. Robinson about if there's a way that you can have an undo button in eCW. Would absolutely love an undo button, but there is no undo button. Why don't we cover that after we do the billing piece? There are some ways that if you, for example, merged an old physical exam that you didn't like and you wanted to just undo it and go back to how it was, is kind of the way Dr. Robinson phrased it. I can show you some ways to maybe know what is going to come in, so we can talk about that. But let's get into the billing part today. So everybody knows the E&M coder, and so this is more kind of a philosophical discussion, not necessarily a technical how-to, but just kind of a discussion about what works best for you in your practice. There are many of you who like to use our templates, and the templates are very much based around these different HPI categories. They have review systems built into them. These are just different. Did we get another? Looks like we have a third person joining us, waiting for names, so we'll see who jumps on. But what happens with using these templates this way is you have the E&M coder can actually count how many categories you review. So how many? Welcome, Karen Doe. How are you?
How are you?
Good morning. Welcome. We're just barely getting started. So we're talking about billing.
Okay.
And so when you use the templates, what happens is you now have 4 HPI categories here. You now have 4 different body systems that you're doing review of systems on, and so it actually counts those systems. So a question we get frequently from new hires and people is, can I just free text stuff? And if I free text stuff, what happens? We've never come out with a hard line that says you cannot free text anything. If that works well for you and you're a good typist and you're kind of doing that in the room, whatever works best for you, and you are confident in your billing skills is what I'd say. You've had some billing training or you kind of know how to differentiate between a level 3 and a level 4, and you can count those things up yourselves. That's great. And so I have no issues with free texting things. And so if you're the type that likes to free text your whole HPI and then you end up including your review systems in your HPI, and you know that you did 3 different reviews, 3 different body systems inside your HPI, and and you can count those things in your head and you can do your own billing, and you've done your own billing before, then that probably works out just fine. We do an annual billing audit on your stuff and to make sure that it's compliant. So anyway, that being said, we kind of come down here so that you can see it counts on a template, and then on the physical exam, one reason we like to use the physical exam is it actually has all those categories, and so it actually can count those categories. Physical exam is the only way that the E&M coder will count your exam. If you use examination, which is for all intents and purposes a much simpler exam and preferred by many, I know, we actually built in the old paper exam right there under CHC exam. These are the exact defaults that was on the old paper note that you used to circle or cross out. And so that's what these entries are built upon, which is a really nice kind of from a brain muscle memory standpoint, you're able to kind of know what review systems questions to ask. And so in some ways this is a really nice way to build the exam. The green arrow merges over the default. You can build in different defaults and things like that, which is kind of a nice thing. However, the exam, this is for the purposes of this discussion, which is about billing in the E&M coder. Examination does not work for the E&M coder. And so then you put in your assessments, and you can see this woman has many assessments from the notes we've been working on, this test patient. So when you're all done with your visit, and you're in your your billing screen. Everybody probably knows this. You click on the E&M coder, and then it kicks you out a number here. It's suggesting this is a level 4 visit. This probably is a level 4 visit. And if you feel good about that, then you just hit accept code, and you're done. It ties the ICD codes for the visit to the level of visit, and you're done. And then you hit obviously the black checkbox is how the billing is submitted, and then locking note right here is how the note gets locked. In order to get credit for their reviews, the note has to be locked. And so that's basic E&M coder in a nutshell. Now, if we break that down, why don't we pause for any questions? Do we have any questions up to this point?
No, I don't have any questions.
Okay. Most of you probably, of the 3 that are on the call, who uses the E&M coder?
I do.
So you said there does,
time.
not all the time?
Not all the time.
That'd probably be my answer. I definitely don't use it all the time. You'll probably notice it in some instances it may be a little aggressive.
Mm-hmm.
Yeah. Is that your observation?
Yeah.
And so it certainly can be, and so I will, when I don't use it, I'm usually downgrading it is what I'm saying. I don't necessarily totally rely on it from my own billing knowledge to necessarily track that. And so I use it maybe 50% of the time. I'm throwing out a number. I don't know. Dr. Robinson or Karen, are you guys using the E&M coder at all?
Chris, I am using it frequently, but I use my own judgment to agree with it.
Okay.
And many times I downgrade it instead of upgrade it.
Excellent. Yeah, I would say that's probably where there's utility in it. Like, oh, I guess that does justify level 4. I feel good about that. I'm going to go with it. Or you've kind of counted it up in your head or whatever. So I did at one point ask a room full of eCW users at a conference that was a very large room, sort of what people's take on the E&M coder was. There was an article in the New York Times at one point talking about how advent of EMRs has actually increased billing fraud across the country. And I said, is anybody worried that sometimes the E&M coder is a little aggressive, or is there any concern out there that maybe with eCW we're actually overbilling things if you strictly carte blanche use the E&M coder? And not a single person in the room agreed with me. All the people up on the panel that asked the question to, and everybody in the room, nobody else in the room stood up. Maybe they didn't want to, but every person on the panel, there's probably 10 people on the panel. It was kind of a clinician users panel. All said, we feel like we're actually finally getting paid for the work that we do. They feel like their bottom line has been improved by using the E&M coder and by doing that. So, grain of salt. I don't know entirely what I do feel like it's aggressive sometimes, and I just think if we all just be a little cautious with it, then that's basically what I would say.
Mm-hmm.
I don't know if anybody else has any great thoughts about it.
I was using it
Chris.
almost exclusively, and what happened when that lady came and did the coding review, she said you're coding 99214s too frequently. So I got immediate feedback. So I just use my more judgment now than I do the coder.
Yeah, and one problem is actually built in. We'll get to your comment there, Dr. Robinson, in one second. Let me comment on that. One issue is some of the templates we build actually, so if you just look at a numbers game, I think on the conjunctivitis template is a great example. The red eye template that I built, which is it needs an improvement as a template. A lot of them do. It it has an HPI that has 5 or 6 questions, and then on the review systems we kind of go down some URI questions, but they're in different categories, and it spits out at level 4 visit, I believe, on a conjunctivitis visit. So that's where you can get yourself in trouble, I think, is that this was a pretty quick conjunctivitis type visit, but you actually if you did do a full exam, you listened to heart and lungs and pushed on their belly and did did the review system that's in there, which hits 3 different body systems, it constitutes a level 4 visit. But in reality, it doesn't necessarily constitute a level 4 visit. One feedback we've been given from our AAPC in the previous coding audit people we used, one teaching point they've always had with us is that level of visit is more accounted for in the chief complaint than actual documentation.
Mhm.
So if that makes sense at all from what I've learned about billing, you can document your way into a level 4 visit, but if the chief complaint doesn't necessarily from a medical decision making standpoint warrant that, that may be overstepping your bounds a little bit.
Mhm.
If a chief complaint is fever, but it turns out just being a URI, and they look well, but you've documented your way out of a meningitis and out of an appendicitis and out of different things. Now you've built a case for having a level 4 visit when actually the medical decision making wasn't. Well, it was because you've ruled out those very serious illnesses, but I don't know if I'm speaking off the cuff or if anybody else has any thoughts. What were your thoughts, Dr. Robinson?
Well, I agree with you that it does seem aggressive, and I have to down code from what the E&M coder says.
Yeah.
It surprises me that nobody in a big meeting felt the same way about it. That speaks to the honesty of our group and trying to, be truthful about it. But I think the issue you're grappling with now about a conjunctivitis being a 1-4.
Yeah.
The problem with, although you might be able to put in enough beans to count that would make it a 4, you cannot make conjunctivitis a level 4 because of the level of complexity. It's too low. In other words, that's where you break down. You can't, if it's, your levels of complexity are either straightforward, low, moderate, or high, right?
Yeah, exactly.
And if the end point of your visit is just conjunctivitis, an anointment, or a drop, and the most you're going to get out of it is a low. You're given a medicine, right?
Yeah.
I think that, I think that's the problem.
Yeah, I would agree, and that's where I think I wanted to have a conversation with everybody about kind of just general things where you want to be a little cautious with the E&M coder. I just merged the red-eye template, which, like I say, needs some help. I don't think these immunizations, I think these immunizations were already on the note previously, and we didn't merge the immunization part of the template, so I'm just going to leave those, but I don't think that that's going to affect. I'm going to go ahead and see how this one bills out. Whoops. Go to my billing screen here. I think I actually put a 213 on the template itself. If you use the coder, and the coder's telling me it's a 213, so that's good. Yeah, that feels better. Does that feel better to everybody else? I hope people aren't billing a level 4 visit for a simple conjunctivitis. So.
One coder many years ago with the SWAP and the URI template, they both kind of have similar symptoms. Many times I have done coding as well.
The URI one?
URI and the structural.
Yeah. What were your comments again?
Many times I have to downgrade those as well.
Correct, yeah.
I had a coder once tell me many years ago that generally speaking, anything that ends in an itis, conjunctivitis, bronchitis, pharyngitis, is going to come in at a 213.
Yeah.
Now that wouldn't apply to meningitis.
Sure.
but generally speaking, what we see here in the clinic, I always keep that in mind when I'm coding. Yeah.
I know there's an ongoing debate out there among some of you about whether or not you can code a strep throat as a level 4 or not. Mm-hmm. It certainly can be a serious enough of an illness with potential long-term complications and requires a level of thought, and you're giving a medicine and those sorts of things that I think if you were to look at some different coding guidelines, you could probably feel good about a strep throat as a level 4. If you do it rather quickly, probably not. So. It's a good question. I don't know. I don't have an answer for it right now, but for discussion purposes. The other piece I want to show everybody is the time-based coder. Is anybody using this at all?
No.
I've glanced at it on occasion as I've seen a patient for a longer visit, and thrown in if we throw this in this conjunctivitis visit. You can change this from new to established, and then you get when they're established patients, they actually have a 5-minute, a 10-minute, a 15-minute. I think if you do this, I'm not sure why that's not giving me a. There we go. Now it's refreshed. So 15-minute puts it in as a level 3. You have to go to 25 to get to a level 4. I think if you're going to do time-based coding, my understanding is you actually do have to document that 25 minutes was spent face-to-face counseling this patient. Mm-hmm. You have to have a statement in there, something like that. And I know that Dr. Jay Moreland has a phrase in a browse statement that he uses on your treatment screen. He just throws it in right here. I think he puts it in under other, which I think is totally reasonable to throw in something like that right here. I can't remember what the name of his template is that he, 30-minute visit, greater than 50% time spent on coordination of care, counseling and coordination of care. So there's that star 30 right there, which would be, that statement would kind of cover a time-based coding approach. The other option to where you could put that is on your actual billing screen. There's a browse section here under billing notes. I don't know that see, there's your 60 minutes spent face-to-face, 15-minute, 25 minutes spent face-to-face. People have already built some of these things into there. And if you put one of those in, let's put the 25-minute visit in on that. I wanted to make sure that that actually shows up on your locked note. So I put a level 4. I got my let that refresh here. You'll notice I've got, there it is on the procedure codes that went in right there. I'm going to lock this note. And I want to make sure that that actually tracked over to my note. That came in, I think we put that in ourselves. That's not part of the billing note that we built. So I guess if an auditor were just looking at this note that got printed and sent to them, they might not see that you actually documented that this was a face-to-face for 30 minutes or 25 minutes as we stated. So I actually favor putting it in where Dr. Moreland does on that other section, 30-minute visit, 50% of time spent on counseling, coordination, and care. That seems to live more loudly in the note than that procedure code note. So that's what I'd recommend today. That's not based on any national Medicare CMS guidelines. So, in all route, if you were under serious scrutiny on your billing screen, that will live right there, and will probably cover you. But probably is a scary word with CMS folks. So I'd put it all over the place if you're going to do that sort of coding. And I think that that's legit. I mean, my experience is pretty limited, but we've never had a rack auditor in here combing through stuff. But just kind of speaking, I think if you legitimately spend 25 minutes face-to-face with a patient, coordinating their care and putting in their medicines and their complicated patients, I think you can use the time-based coding relatively safely. And so anyway, that's what I'd say to that. So moving into other billing tips and tricks. So if you guys notice when we got version 10, let me unlock this note. This is a test patient. Oh, but it's on Martha's schedule, so now Martha has to be the one to unlock it. Let me go to hopefully another outstanding open note here. Okay, so on your, you guys probably noticed I use that details button a lot to navigate. That's just kind of been my workflow to get to this band, which keeps me from scrolling by clicking on an arrow 100 times, which I hugely prefer. So as I get to my billing screen, whoops, as you click on add E&M, so that's when you're not going to use the E&M code. You're like, yeah, I think the E&M coder is not going to be accurate on this visit. I know this is a level 3. I'm just going to go here. You'll notice that this has been fixed. When we upgraded to V10, these got all out of order. I reordered them and fixed them so that it defaults to your standard E&M and then your new patient's right underneath it. So you guys have probably all seen that. And then you have your preventative are the next two. So those are obviously your most commonly used ones. So that's really the only other billing piece that I have. Is anybody out there still using the, forget what it's called even because I don't use it anymore, Super Bill?
I do.
Do you?
I do when I'm adding like fluoride varnish.
Yes.
And maybe like if I was going to give somebody Toradol,
Yeah.
I would look for it there.
Okay. Excellent.
That's kind of my go-tos. Or Rocephin. I did Rocephin yesterday, so I looked for it there.
On the procedures one or?
Just off the Super Bill.
This one right here, family practice OBGYN.
Yeah.
So
if you go to the adult or the child, mine defaults to the OBGYN.
Oh, it's under OBGYN.
I don't know. I think it's on adult. I think that's where I found
family
the Toradol.
Okay.
Maybe.
Yeah, I don't use this with a lot of regularity, you can tell. So
Yeah, there's Toradol.
Toradol right there, yep.
So if you're going to order that, how do you do it?
My MAs put it in. There's a procedure that's been built, and it just goes in and looks nice where it is. And
Okay.
I haven't asked any questions, so we should probably. So that's a great thought. Kind of getting off subject, but we do need to start tapping into this therapeutic injections functionality eCW has built in right here, and build those into these right here. We need to have Toradol, Depot. We need to have all those Bicillin. We have all those built in right there, and that's a project that needs to happen, like many other projects that need to happen. Anyway, that's billing in a nutshell. Does anybody have any other billing thoughts before we get to Dr. Robinson's question about an undo button?
Can I ask another question? I'm sorry.
Sure.
When you're on the notes there, show me again, how did you get to that toolbar with, the billing and all that stuff without having to go out of the notes?
Yeah, so there's a couple different ways to get to that. I don't know what they call it. I call it the linear navigation button. So you can click on a blue hyperlink, which is oftentimes just as fast, and it opens this rack of options up here, what I call kind of linear navigation. And then from here, your billing screen is right there, a calendar, totally intuitive, but that means billing.
Okay.
Well, it's yeah, when you click on that, then it takes you right to your billing screen for the visit.
You also did it to details.
Yeah, I did it. My hand just goes automatically to details every time because it opens the same screen. But any blue hyperlink gets you to this right here. Gets you to this right here. And if we go down and look at those, that's how you can jump to allergies, medical history, complaints, medication. So that's your current meds, your vitals, your HPI, your family history, your social history. If you hover over them, they give you the name. You start to learn the pictures over time. Surgical history, hospitalization, review systems. You get your exam, your regular exam. Love that there's two of those. Procedure, diagnosis, treatment, appointment or coding, and then preventive medicine, labs, diagnostic image, alerts, review patient orders, and then eClinisense. Claim, which we don't necessarily go to. eClinisense is right there. Oh, apparently not. I think you have to be on the treatment screen. It's either here, which gets to eClinisense, or here.
Yeah.
My brain tells me that it's right here. And then you got claims you don't really use. You can get to the templates button right here, which I actually like. Instead of, that's probably a nice little piece to learn. I should start using this more frequently, the templates button. I think that's a V10 edition. It could have been there the whole time. I've just always gone to here. I've got to close out. Because if you want to merge just certain pieces of the template, then you have to get to this templates button. You can't merge or copy templates from your favorite templates. But that's actually a really nice piece to know that it's right here, so you don't have to actually close out this screen, but I can get right to templates from here. I like that.
Now, I have
Well,
a
that's going to
question.
help me
Yeah.
because I always go out of the note completely back to the
Yeah.
schedule list to get the billing. It's kind of, that button at the bottom.
Oh, No, yeah, the billing data button from the schedule.
Yeah.
Oh, no, yeah, you got to get there through that calendar. Yeah.
Okay, calendar. Thank you.
Yeah, you bet. Let me show you one more time right there. Appointment.
Okay.
I guess because they call it the appointment screen because that's where you can put in when their next appointment should be. And speaking, sorry, I get kind of all over the place there. My attention deficit problems start to come out. Really quick on these, there's a clinical decision rules built into eCW to where I can, for different types of visits, if we code a diabetic visit, then we can create a clinical decision rule to where the patient gets a reminder to come see us in 3 months automatically without anybody having to do anything. Got to build it. Another project list. That will help with kind of the question you talked about with being in the diabetes, kind of the scheduling follow-up versus, Dr. Woolsey talked about we should have a systems-based approach to, getting patients in every 3 months. So it's there. We got to build it. So there's your appointment screen. There's your preventive. Anyway, if you go down the list, that's how you get to those things.
Thank you.
Yeah, you bet. Yeah.
Can I ask another question?
Sure.
I forgot how we got to the assessment screen, how there is a contain box. Or when you look at assessment, you can do start with or contain. How do you change that?
Yes. Uh-huh.
Okay, how do you change the default to like start with? Because mine's on contain. I forgot. You first have to do it once, but I forgot how to do it.
You want it to stay on contains, or you want it to stay on starts with?
To stay on contain.
There is a way. I'm going to have to play around with that for a minute. Why don't you and I stay on the call after, and I'll see if we can get there, if anybody else wants to watch that. I like mine's on contains, but it somehow has reverted to starts with, and so maybe it's right there. Default.
Do you go to EMR to do that? I remember
let's check right here. Sorry. There it is, Karen. All you do is put a check in this default. So if you put it in, you can have a default to their problem list, you can have a default to previous assessments, or you can have a default to all assessments.
Oh, okay.
And then put it on contains or start with whatever you want, and then put a checkbox in default right there.
Okay, thank you.
Yeah, that fixed mine to default to contains every time. I'm glad we discovered that as well. For some reason, yeah.
Patient specific, or that works?
I'm pretty sure that works for all.
Oh.
Yeah. We'll have to watch that going forward, but yeah, that's a nice piece. Yeah. Yeah, eCW, super customizable. That's one of its good things and one of its bad things. So yeah. So Dr. Robinson asked previously, if we could jump to that. Does anybody else have any other thoughts? Asked previously about an undo button, because he was saying he would sometimes go in and merge like an old exam off of the gold caret. So he would do like the gold caret right here. Good morning. Hello. Good morning. How are you? Good. He would gold caret things in, like he would do this, and then merge it in, but then not like it. So I guess one thing I would say to that, and he would like to undo that like a Word document, which I would love that feature, by the way. We should submit it to eCW Ideas. They have, so one thought I would just suggest about that is to actually look through this before you merge it. Is that where you're getting to it, Dr. Robinson? Is that mainly where you're arriving at merging these old notes?
Well, also, there's a feature where you can pull in assessments, and it also pulls in the treatments along with it.
Oh, yes.
And a lot of that stuff is not correct anymore.
I totally agree.
And the only way I know to undo it is piecemeal,
yeah, which is time consuming. Let me show you something.
Like, you can pull in a lot of stuff, I think, by pulling in an old assessment with a caret. I'm not sure how I do it. I'm scared to try anymore because it's so hard to undo.
Let's see if this patient has a bunch of stuff in here. So if I merge these last two assessments, it's going to pull in the whole plan for those as well. And sometimes that's starting new medicine. Sometimes that's checking a lab that you already checked that you don't need to check again today, right?
Right.
I totally understand that. One option to not do that is to use the templates feature, which allows you to merge certain parts of an old note. let me show you what I'm talking about. Well, there's two different ways. You can actually, let me get to the settings way to do it first. You can actually go to settings. I don't think this is a good option because sometimes you have settings and then you have, it might take me a sec here. I might have to come back to this.
That's okay. I don't know.
There's an option where there's an option on the gold carrot that that you can say don't pull in the treatment plan with it. Okay. Okay. Thank you, Susie, for coming.
Welcome. Thank you.
There's an option we can maybe stick on and look at that. Let me show you the best way to do it. So if you go to templates and you go to patient specific, I think patient specific templates are an awesome, awesome feature. I go to patient-specific templates, and then I go to the note where I have that previous plan that has all those diagnoses on it, your 4 major problems. I click here. I can look at the note and be like, yeah, I want to use that. I want to use that treatment plan. But let's say I don't want to. Let's find one that has several diagnoses on it. Let's do that one. So I like this note right here. Now I use this screen over here to merge certain aspects of the note that I only want. So I can actually take out the HPI because I already wrote the new HPI today. I obviously don't want these things. So one thing is you can click this button here and they all go away. I can just go to assessment because I just want those assessments from that note. And then I just want, you could even do, let's say you do like the labs that you did, and if you did, you could just do labs right here. Then it would only pull over the assessment with those labs if you're repeating. And then you can do a procedure that you did, but it only pulls over those pieces of the note. Does that make sense?
Okay, so this is template.
Yeah.
I don't have to have done anything previously.
Yeah.
It's just pulling up my old notes on this patient-specific thing.
Yeah, exactly. So if you go to notes and then you click, the templates default to generic. If you change it to patient-specific, and now if I leave it on medications, I think that's just under the treatment, then it will pull over those medications. So if your previous note said continue, 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 and you like that, then you would want to include it. But if you're going to, you don't, for whatever reason you don't want that, you can merge just those particular pieces of the note.
All right.
And so let's say you don't want to merge the labs you did on that visit, but you want the assessments and the treatment. I'm going to do, and you can copy those, and it'll replace any part of the treatment that's there. It'll replace. So copy replaces, and merge only adds to. So now I only chose to merge those assessments only, and that's all that pulled over.
Okay.
That's new to me, and I think it's very helpful.
Say that again.
That's new to me, I think it's very helpful.
Yeah, merging different pieces of the template is awesome. Also, yes, let's say if you go back and you want to merge just the physical exam from that visit, let's say you did a really nice knee exam, and you documented it really well, and you want to just pull in that note. So you go to patient-specific, and you see the reason here is going to be knee exam. You look at it, and you say, yep, that's the one where I did the really nice knee exam. I'm going to do, take that. Did you see how I did that? Click all options, then click it again, and now you're blank.
Yes.
I only want to merge the physical exam, the assessment, the treatment notes, but not the medications or the labs. And now I do copy. And that was a bad note to choose because it didn't have anything on it.
But you want to copy or merge, because if you copy, it'll just copy exactly what you just on physical exam and blank everything else, right? You want to merge it.
Not if you've used these checkboxes carefully. If you've taken out HPI, you already wrote your HPI, this needs to change that it doesn't default to those. HPI, physical exam, assessment, and this is a patient-specific template, treatment, and then I want to do my labs. Trying to find us a good complaint on this test patient. I'm wanting to use test patients only because we're publishing these through YouTube. I don't want to be, obviously can't be having any patient information floating out there.
So when you copy,
Here we
the
go.
copy should only copy the part that you choose, right? The section that you choose.
Yeah. So here's a pretty involved visit, right? We got 4 referrals for 1 diagnosis. We got labs. We got everything. So I look at that and I go, I want to repeat their microbiome and I want to repeat their CMP today. I'm also going to re-refer to podiatry. So you can put those. You can kind of make a quick assessment of what you want to duplicate for the visit today, and then you can choose down here what you want to pull over. There's actually not a referral section. I thought that there was. That's probably just under treatment. But mainly labs and not labs is a big help. So I'm going to choose those things. Let's say we don't want to do those labs today. So I just take labs off, but then I merge the rest, or I'm going to copy the rest. And now you can see it's copied that exam from that last visit because that's all I chose. The HPI, that's all I chose. And then it's pulled in the assessments and then the medications that I started on that visit only. Notice it didn't do any of those labs. Looks like referrals can't come over again. That's actually probably kind of a nice thing because you don't want to necessarily duplicate referrals all the time. And so then from here, because I saw that those were start medicines, now you'd have to go in here and change these to continue, which you can do with just one. Yeah, change these to continue. So that's just one way to do it.
That's a really nice function. I think you'll just have to practice and get comfortable with it. Because you can
Yeah.
answer that really easy too.
Yeah, you'll get better at kind of carving out pieces from old notes. Like I do all the time. I'll carve out pieces from old notes and load them in. That are obviously very structurized pieces of data that aren't necessarily going to be new to the visit today. That doesn't look like you're just kind of copying everything over and billing it again. Yeah, that would be a little piece I would suggest, Dr. Robinson.
Thank you, Chris. I gotta go.
Thank you.
Okay.
Thanks,
Thanks,
Chris.
thanks everybody. Did
Alrighty.
you want to see where that setting is to not pull over the whole treatment plan? I could try to find it and maybe I'm actually going to be out at SDR today. Maybe I'll come grab it and we can look at it.
Oh, okay. All right.
Okay.
That's fine.
Have a good day.
Talk to you later.
Okay, bye.
Right. Bye-bye.
Thanks, everybody. If you have any questions on this, feel free to mjellybean me or Jennifer or your clinic director. And we'll see you next Tuesday. Thanks. Bye-bye.